Готово. Майкл первый.
Я.
Ага, хорошо. Но вот у нас уже была одна секция, посвященная искусственному интеллекту в эндоскопии.
We already had one section about endoscopy. It was finished wonderful because Alexander Regici, our professor from Italy, told us the following, that after 5 years we will have only capsules and nurse and artificial intelligence, and that's all. This is a very positive point, but still we'd like to discuss it in more detail in our MED talk. We have two keynote speakers today, who will discuss these topics, and I'm ready to introduce them to you. Sergei Kashin, Chief Specialist in Endoscopy, Department of Health and Pharmacy, Yaroslavl region, and Michael Hafner, IRCAD Clinics, France, Head of Internal Medicine, Professor, one of the key specialists in artificial intelligence in Europe. So let's begin our talk. Sergei Vladimirovich, you have the floor. Thank you, Evgeny. Today we have a number of presentations which will give us more detailed insight into this problem and discuss with you first and with the audience also the topic of the trends of the artificial intelligence world and where our life will move in the nearest future. Because Mr. Repic's forecast that after 5 years from now we will have only smart endoscopes and the role of the doctor of an expert level will be reduced to interventional endoscopy. Well, to some extent, this could be a forecast, and it could come true, of course, because now the focus of main groups and main developers of such systems is made on a high-performing diagnostics, and it is absolutely grounded and reasonable. Michael, could you give me the clicker? Yeah. Okay, I'll do my best to make very brief welcoming part, because the keynote speaker today of our MED talk is, of course, Michael Hafner, who prepared for us not only some data about the smart endoscope, but I think it's very useful and very important for all of us. But he will also share with us his unique inventions and developments in the scope of his cooperation with the IT team of the university, of the Austrian University. And he's currently is actively involved in the development of such smart device together with Pentax company, and Alessandro already mentioned this, that this device is already about to be implemented, and we are eager to use it in our endoscopic departments. I'd like to start with the slide which was partially commented by Mr. Hafner. It is very important, by the way, on one hand, scientific interest to the decision-making system support of a doctor is growing, and is growing significantly. If we have a hindsight to 1990s and noughties, now we see a huge progress. On the other hand, please take a look, 2017, 50 publications a year. What can it tell us? It tells us that the real scientific research related to the approved medicine and artificial intelligence are not so many, despite the fact that we do have publications which brings us and reveal to us this problematic. It is huge, and I already showed this slide in the previous session, but I cannot miss it here too, because this is not a hype, not a buzzword. This is the opinion of British journalists that artificial intelligence in endoscopy is in one line with great achievements which help to diagnose cancer and which have huge influence on the development of oncology and saving the lives of our patients. And of course, new endoscopic technologies are able to detect smallest structural changes of the tissues, and then amount of data is growing. Just take a look at the example of complicated diagnostic of antral stomach section of helicobacter pylori associated gastritis, with different pathological lesions, with distorted vascular and superficial pattern. And basically, we face these patients in our day-to-day practice. We have a lot of patients like this in our practice. And please support me that it's very difficult to make a decision whether these or that section could be malignant. Make biopsy from such sections taken from the stomach of the patient, where there are 10, 20, or even more such distorted metaplastic sections, is very difficult. And in our conditions, and I think in Western conditions, it also costs a lot of money. Computerized diagnostic systems and decision-making support systems could improve endoscopic diagnostic and characteristics of lesions, which would help us to avoid excessive biopsy and would allow us to improve efficiency of endoscopic examinations and reduce their cost. If we take key approaches to the solving the problems of artificial intelligence and artificial, there are two approaches. Traditional approach, the stages are outlined on the top of the slide, and deep learning approach, which Mark Fafnell told a lot today in detail. Both approaches are focused on several tasks. Please take a look at 4D protocol. This is an algorithm to diagnose neoplasia in stomach, which has been considered in detail by a Stomach Cancer Committee in 2015. The World Endoscopic Association actively considered this protocol, which is now not included in WS standards. However, this protocol implies detection of neoplasia, providing a demarcation line, differentiation of the tumor, or differentiation diagnosis between malignant and benign lesion, and depth of invasion assessment. Both these approaches of artificial intelligence are aimed at the detection of lesion using assistant program, and characterize these pathological neoplasms. Very briefly about these approaches. Traditional approach has been designed by our team of specialists and by our IT team together with Herbert Edelsbrunner from Graz University. Could you please play back the video? And here we say that based on the structural changes of superficial and vascular pattern of epithelium, which we can detect using the endoscope of 115 times magnification in the narrow spectrum regime, we are able to detect pathological lesions of this pattern. However, the program assists us in efficient interpretation of these changes and characterize them as the earlier form of cancer, neoplastic lesions. And the second section, 3 mm size, if we magnify it optically, has absolutely different characteristics. And it is very important in our practical work, because take biopsy from 3 mm will not be taken by all endoscopists. And the first case was the case of the early cancer. Such system which allows to assist the doctor in decision making allows us to avoid incorrect diagnosis and serious diagnostic errors which can entail changes in patient treatment. A very unique cancer to be flat, absolutely flat, and the program can detect it as a neoplasm easily. Another example of decision-making support program is a case from a Japanese team which used such approach to differential diagnostics and characteristics of lesions in the colon based on endocystoscopy. Professor Kudo team and Dr. Mori many times presented these results at many international congresses. The importance of this work is that it does not allow to tell whether it's a benign or malignant neoplasm. It allows to identify precision of this diagnostics and tell the doctor that this neoplasm has 88% precision of diagnostics, which is very important for an expert. This system does not replace the doctor, but this system assists in the decision-making for a doctor. What's the purpose of this system? To make a proper decision during colonoscopy and resect those neoplasm with malignant potential, and maybe along with the strategy accepted in the German community, resect and discard some hyperplastic polyps which doesn't have malignant potential could be left behind. Another wonderful example is deep learning in the intestine. Together with Misawa Group, this approach demonstrated opportunities of artificial intelligence in diagnosing pathological lesions and polyps in the colon. This is the system which is provided by several providers. Alexander Repici demonstrated GiGenius system of Medtronic. This system was designed based on Olympus equipment. Michael Hafner will tell us about unique developments of Pentax. And you can see pathological polyps, which system can easily detect and allows to fix and to record these lesions. You may ask why, because these lesions can be seen without it, but in the end we will speak about the quality control, and this system provides an opportunity not to miss them. When Professor Repici was distracted for a goal of Italian team at the World Cup, he was distracted for some phone call and just turned a little bit from the screen, and the endoscope at this time went out for 5 centimeters distally, and at this point the doctor may just miss the pathological lesion, and the system, which has sound assist, can signal and give an alert that there was some lesion and we should come back. This is one part why such programs are needed. The second part is just to calculate and read them and put them into the protocol, which will allow to give the higher polyp detection rate in the colon. And other 3 components which we should discuss in the end. Maybe the key aspect is the quality control, of course, which Evgeny Nikonov pays a lot of attention to. In Moscow, they create expert centers which will receive huge traffic of patients, and a huge traffic of colonoscopic examinations should provide high quality control, because it's not possible to process manually such huge amount of data. Previously, I showed the unique results of Yuko professor team from Japan. This year, we invite him to Yaroslavl to our congress. They have 50 to 60,000 colonoscopic examinations a year. It's 5 times higher than in our big endoscopic centers. And of course, the normal detection rate couldn't be calculated. It's unreal to calculate it manually. And such programs allow to do it easily and provide monitoring of the situation on the quality control on a weekly or monthly basis. Now I'd like to show you a few our latest developments. This is the first demonstration of the program we are working on. This is automatic detection of the blind gut dome. And this is a program we are working on. You see the endoscope moving towards the blind gut entrance, and this blue line started to signal that it detected, based on the images, the huge amount of images which are already in the database. It detected this zone, and as soon as we bring back the endoscope, this blue frame disappears, and the program is not possible to detect the entrance of this gut. On this frame, you can't see this important anatomic milestone, which allows to detect the completeness of colonoscopy. This is the key indicator of the contemporary of the quality of contemporary colonoscopy. The American endoscopic community is moving towards it. From the point of view of healthcare organization, it is very, very profitable. At the latest Gastro Week in Douglas Rex, in American Douglas, is the key subject matter expert on colonoscopy of the American endoscopic community. He said there is no picture of the blind gut. There is no ground for the insurance company to pay for this examination. If there are no other points which or anatomic complications which could prevent to bring the endoscope towards the dome of the blind gut. Another development of ours, very fresh and recent. Just I received it right tonight, last night. The whole team was working on that very late, just to develop the algorithm of detection small polyps. And today we can be proud of having such a program, very similar to Mr. Repic's program, and which Mr. Hafner will demonstrate today. These technologies require certain effort, certain careful work, and please pay attention that they are available today to our programmers, developers, and to our expert groups who are involved in designing of such programs. What else I wanted to tell you? In conclusion, once again, I'd like to focus your attention on the fact that computer-assisted systems of decision-making are able to work very quickly with big databases. They are never tired, they never lose concentration, which is very important in a course of colonoscopic examinations, which, if they are done more than 10 a day, can lead to the tiredness of the doctor. They improve endoscopic diagnostics and classification. Professor Repic showed us the data and the new data today. This data will be provided in the States on the gastroendoscopic week. This is second opinion, which we really like. This is a buzzword today. And finally, this is training and testing of doctors, endoscopists. It's very important. When we have a huge amount of clinical cases in the database, we can use them to carry out tests in a course of Moscow doctor program, for instance. Evgeny Leonidovich, you will support me. And so these questions, these issues which you can see on the screen, of course we will do our best to discuss them today, because the best algorithms are still not found. There is no interaction between different groups of experts. Everybody tries to design his own program. There are very few programs who are adopted to the real clinical practice and was proven and tested legally in their countries. But I believe that our future is really, really bright. And just in the end, I'd like to show you that there's no ground for being pessimistic. This is an area for optimists. And just take a look how great people can error. Thomas Watson in 1943 told us that the world market may be only for 5 computers. And now just take a look what the global computer market looks like now and how it is forecasted, especially in the area of computer-aided decision-making in different areas, including medicine. And only joint efforts of different teams, groups, and companies can provide development of validated systems which will help us in controlling the oncological diseases. If you ask me whether this mission is possible or not, AI for endoscopy, of course this mission is possible if this problem is handled by such great experts and even grants in the area of endoscopic diagnostics and creation of modern computer-aided decision-making programs. You may recognize some experts in these pictures from European and global community, and the future president of Helmut Messmann in the right bottom picture. Thank you very much for your attention. Thanks a lot, Sergei. It is very pleasant that we have our own developments in Russia in the area of artificial intelligence, and surprisingly enough, they are respected abroad. Now I'd like to ask Michael to tell us about his experience in the area of artificial intelligence. And Evgeny, just first, please, smart endoscope first. Smart endoscope should come first. This is special. My special request to Michael. I think it is very interesting and learn the opinion of the leading expert how a smart endoscope should look like in the nearest future. Wonderful. Thank you very much.
Thank you, Sergei. You all have smart homes, so you have smart cars. There are a lot of smart features, but we are still working with technology which has been invented in the 19th century. So although endoscopy has evolved and we started from mirrors to fiber optics to video chips and now to HD and wireless endoscopy, think of capsule, we still have very much passive instruments. We push them, we rotate them, and we are the director of endoscopy, and we are the only director, and we are also the interpreter of our pictures. And if there's a problem, my endoscope doesn't talk to me. Unlike your car, where you have a diagnostic plug, I have to call a technician, I have to send the endoscope away. So, strictly speaking, endoscopes are very stupid. So, the question is, can endoscopes be intelligent? Well, I've divided it into chapters. And first, you can design an endoscope in a smart way through well thought out construction, using new materials for the components and intelligent craftsmanship. And some of the current generation of endoscopes has already some of those intelligent features. For example, there are colonoscopes which you can stiffen, so you can make them softer or less soft depending on your needs. You have inflatable balloons on top of your endoscope. So like in an airplane, you can stabilize your endoscope and maintain a difficult position. And you can throw away parts of your endoscope, like this scope you see on the right. We've seen large problems with hygiene with our instruments, and this part you can remove here. The elevator is the most critical part. So one company has come up with a solution that you use it and then you throw it away. Another technology is GI. I told you can stabilize your endoscope. So when you're performing an endoscopy, usually your endoscope is moving freely in an organ like the stomach or the colon, and you don't have a very good stable position. So with this new device, what you can do, you have a built-in balloon which is so thin that you don't notice it during routine endoscopy, but once you have reached your goal, you can inflate this balloon using this pump, which not by chance is called Smart Pump, And then you have a very stable position with your instrument, which allows you resecting polyps also in very difficult location. So here we have smart design, which helps us improving our results. Another thing is that endoscopes are made by camera makers. If you look at all the endoscopes on the market, they're all made by camera makers. So we have a lot of optical features built in, like very high resolution CCD chips, we have zoom endoscopy, and we have filter technology like you have for Instagram in order to manipulate our pictures. And we also know very well how to store our pictures and videos. And this is another example. Here you can see a latest generation endoscope. On the left side you have the white light, but on the same picture you can also get an optical filter to enhance contrast. And you can see here that we are allowed to zoom into the picture, so we have optical magnification like with very good video cameras in order to improve our diagnosis. But and other features are autofocus and auto exposure. So like with a camera, you don't have to think, where is my focus? You don't have to think, is the picture bright enough? So there's a lot of things that is already smart in our today's endoscope. And we have also detection sometimes for blood, like in capsule endoscopy. But what if car makers build endoscopes? Well, probably we would have a lot of safety features built in, like airbags in your car, or diagnostic parts in any car, or sensors warning you if the brakes are gone.
Is it yours?
This is my car, which is not a very smart car because it's a very old car, so there's not many safety features on this car.
How much do you have? How much cars do you have, Michael?
Not enough. They're never enough. So.
And what about Alfa Romeo?
Those are the best, but those are the least smart cars. So we could expect other features if we have input from other makers as well. So let's come to intelligent endoscopes. Sergey mentioned artificial intelligence, but of course artificial intelligence is only one part of smart endoscopes. So a really smart instrument can also use positioning like GPS in order to give us the location inside the body and compares it to our goal. And initial steps in navigations have been around for some years. You have from Olympus the Scope Guide, or from Pentax the Scope Pilot, but we are dealing in a very difficult environment. Unlike cars, we don't have maps, and we operate not in roads, but in flexible organs and with flexible instruments which change their shape. So this is much more tricky than with cars. Currently, the biggest area of interest is lesion detection, and I'm going to talk about this a little bit later on. And as we've just seen these days, the first generation of artificial intelligence system is already around, but still it's external boxes, and we expect the next generation of instruments to have this technology built in, so we don't need any additional computers to rely on image recognition. And this is just an example. This is the Pentax Discovery System. You're among the first in the world to see those pictures. This system is not yet on the market. And as you can see, even before I see the lesion, the computer detects my polyp and alerts me so I don't miss the polyp, like in this case. And you can see diverticular on the left, so it can reliably distinguish between normal structures or non-interesting structures and the polyps I'm looking for. So the smart endoscope of the future will be not just a black tube with a video chip, but will be part of an integrated platform. And we'll have more software interfaces, we have interactive software, we'll have navigation, and we have computational anatomy to plan our interventions, and we might have augmented reality, virtual reality, or mixed reality. But at least for me, prediction is very difficult, especially when it comes to the future. It's very easy to tell you what was yesterday, but I think it's almost impossible to tell you what's going to be tomorrow. But I'll try. One potential field of interest is molecular endoscopy. As you've seen, we just use pictures for our procedures, but we can look beyond the surface. And one topic is autofluorescence. You can see this in the video clip on the right-hand side, which has never taken off so far. And another technology is confocal laser endomicroscopy. So with my endoscope becomes a microscope, and I can see cellular structures, I can see subcellular structures like red blood cells or tumor cells or nuclei of cells. And combining this with antibodies and peptides, I might see structures which aren't even visible with microscopy. Just like immunopathology, we might be able to detect lesions by using special antibodies. And there is the first data already available. We treat our patients, but we don't know if all our patients respond to therapy. And one way could be to use those antibodies and molecular endoscopy to predict if a patient is a candidate for a certain kind of therapy, in this case for antibody therapy with TNF-alpha antibodies. And the future will be therapeutic, that's for sure, so we won't do colonoscopy in 5 years, we won't even do capsule endoscopy, but we will use some sort of endoscope for surgery. And robotics is already here in surgery, but it's much more difficult to integrate robotics into a small endoscope. But we'll see in the future robotic arms which are steered by a console from an operator, not directly at the patient, like we've seen for surgery in the last years. And we will be able to remove tumors faster and much safer than we can today. You can see this is an early prototype of an endoscopic robot developed in Singapore. And as you can see, you steer away from the patient with a console, you steer the robotic arms, and then you perform your procedure. So coming to my conclusions, today we are leaving standard endoscopy and moving to navigated endoscopy. We are at the beginning of the artificial intelligence era. The next step probably will be robotic endoscopy, but I think this is still some years away. And then we have what the authors of this paper call intelligentized endoscopy, where we have virtual reality, augmented reality, we have tracking and navigation, we have robotic manipulation, and we'll have what they call multifunctional theranostics. Thank you for your attention.
Я все-таки никак не могу
Well, Michael, still, in your opinion, nurses, capsules, and intellect, when will it become a reality?
Much of what I've shown you can only be done if funds are unlimited. In daily healthcare, money is the big issue. So before we get there, we'll see many intermediate steps. We'll see nurse endoscopy because we don't have enough men. We won't see capsule endoscopy, I think, for routine colonoscopy, but we'll see biological markers. In the future, people won't have to undergo colonoscopy for having cancer screening. So there are many potential developments, and as I've just told you, predicting of the future is almost impossible. So let's see, and let's try to participate actively in the development of those new technologies.
Понятно. Значит, Майкл...
Clear. So Michael probably should work for the Ministry of Foreign Affairs. He's very diplomatic, I understand. Well, dear colleagues, perhaps some of you have any questions? Any questions from the floor? If no questions, well, we move on to the second part of our talk.
Sergey already showed us his experience and told us a lot about the development of artificial intelligence in colonoscopy. And in colonoscopy, we already have quality assurance. So we know that we have to improve our quality in order to improve the outcome of our procedures. And artificial intelligence has just started. As we've heard today already, there's the first commercialized system on the market, the GI Genius. And our initial experience suggests that we have a high detection rate for polyps, but we can also have early issues like false positives which have to be sorted out in the future. And the first generation was very noisy, but we are already at the second generation. So those are early stages, and those are the children's diseases of new technology. Other systems will arrive soon, and I will talk a little bit about a system which will be available in Russia very soon and in the rest of the world. It's the Pentax Discovery System, which is currently pushed to the first users. So I've been involved in the development. I didn't invent it. I'm way too stupid. I'm not smart enough to invent a system like that. But I've been involved in the development and learning phases. So in the first phase, just to give you an idea how you train artificial intelligence, we recorded colonoscopies. We marked polyps and we classified them according to an established classification, and then we resected all the lesions. We then compared our classification and checked if it was valid with the histopathology report. And then in the second phase, the system was tested with a test set of pictures. And then we moved on to phase 3, where we gathered data in real life. And the next phase will start soon. Colleagues from Russia, like Sergei, will be involved in a large multi-center study over the world, where we prospectively will examine the results of this exciting new technology, and this will start in spring. So currently the system is cleared for the detection of polyps, and if you look at the video on the right-hand side, there's a polyp. Sergei, do you see the polyp?
But just now.
Yes.
Yeah.
Sergei is one of the leading experts in this country, and Evgeny the same, but everybody, like me, have issues finding the polyp. You can see it here. It's this, what looks like stool is actually a polyp. It's covered by stool, but it is a polyp. And those are the lesions we must not miss, because the patient might come back 5 years later with cancer, and that's because we didn't find a lesion like this. So these systems, these AI systems, in real time, so while we're doing the procedure, alerts us that there's a lesion which we might have missed. And the computer is also much faster than we are, so he can detect several lesions at one time while we only focus on one lesion. And all kinds of lesions are detected by the system, and it works with white light, it works with the filters which are shown here, and so we can use it under all circumstances. And this is one of the videos. This is a polyp. Let's see, okay, video starts. This is a polyp, you will see it in a second, which I haven't seen yet, but the computer already has found it. So those lesions might be easy to develop, but as you can see, it's a very stable. The computer follows the polyp over time and recognizes it before I even spot it. Next example, again, a polyp which is easy to spot, but I don't see anything right now, but you will see in a second. The computer already found the polyp. I'm not even there, and my AI system, my discovery system already detected my polyp and alerts me that I have to take a closer look at this particular area. Well, you might say everybody can spot a protruded polyp, but this is almost invisible. This is a very small polyp which is flat, and even here, reliably, the computer detects it.
This is the most difficult lesion for
Yes.
detection.
Those are the ones which are missed easily, and those are the ones we expect to find more and more with this kind of technology. And I'm going to show you another example from our initial series. And again, you have here the polyp. Now it's gone because I moved my endoscope.
Very small lesion.
But it's a very small lesion.
Less than 5 millimeters in
Yes,
size.
it's definitely less than 5 millimeters. And the computer accurately alerts me that there is a lesion I have to detect. And as you can see, this also works with filter technology. So, is it perfect? It sounds like the perfect solution already. Well, yes, it is, but almost. We have too many alarms, like with alarm system in your house. Sometimes we get alarmed, although there's no burglar. So stool sometimes can trigger the network and is initially detected as a lesion. That's because we use lesions which are covered by stool to train the system, so we have to fine-tune the system. And sometimes stool is actually a feature of a polyp, like I've shown you before. And we are very positive that we can reduce those false alarms in the near future. So here's an example. Those are both polyps which are covered by stool. And you can easily imagine why AI might get confused just by seeing stool, because we use those lesions also to train our system. And here is just a case where it alerts us in a false way, just in the beginning. Watch closely. So here we have some stool in a second, and we get an alarm. As you can see, stool might trigger the alarm, but on the other hand, we can also detect several polyps at the same time, and diverticula ignored safely. So again, and another thing, we find so many lesions. And the system is so sensitive that we get a lot of lesions, and not all of them are really relevant for a patient. Some of them, or many of them, might be small hyperplastic polyps in the left colon, and we can actually leave them. We don't need to resect them, but the computer doesn't know that. The computer alerts me that there's something, and I have to take a decision. So maybe we have to change our strategy. We can apply in the future probably a detect and forget strategy for certain lesions, so that we just leave those small hyperplastic polyps without resecting them. So in conclusion, AI systems, although they're in their first generation, think of your first generation iPhone, it didn't work well, but AI systems already work quite well. They detect both sessile lesions, pedunculated lesions, and flat lesions. There is no delay. Today's computers and algorithms are so fast that we can work in real time, but we still have some false alarms, mostly due to stool, and we detect lesions we usually would ignore as doctors. We're not as rigid as a computer. Sometimes we're fuzzy, so we say, okay, forget about this. But the early experience with the system shows us that we can expect widespread use in the near future. However, we still have to talk about money. As always in medicine, money will be an issue. And with that, again, I'd like to thank you for the attention and the invitation, Evgeny and Sergei, to come here to Moscow.
Огромное спасибо. На самом деле это
Many thanks. This is a big breakthrough if we take a look at these technologies, and as sooner as they come to Russian market, the better. The other thing is that it happens very long in our case in terms of registration and release of new technologies in the market, in the Russian market. This is a big problem. Myself, as a gastroenterologist, can give you a simple example. From the time of go-to-market of a normal medicine to the emergency in Russia, 5 years. It's 5 years' time. Simple example, dexamethasone medicine. It appears in the States in 2009. In Russia, we get it only in 2014. The same way we have a lag in registration of medical equipment in endoscopy. In the whole world, they use caps, cylinders, different vessels to enlarge the endoscope lumen to have better visibility. So far, it is very badly registered in our market, in our country. But we should not be very upset about it. I believe that nevertheless, we don't have to gain a lot of momentum with the import replacement. We still need global experience, and this experience is built very actively not only in Europe, America, and also in China, where they have the biggest amount of ongoing examinations and research. I just had a talk with Piotr Rybakov. He showed me recent publications where the average amount of examinations 100, 150 with capsules. So there's a huge amount of examinations. For us, so far, it's just a big luxury. Nevertheless, I'd like to ask Sergei to express his opinion when amid not very, in the conditions of not very rich Russian region, we will be able to overcome all complications and work at the same level as our colleagues in the State and Europe work. Evgeny, thanks a lot. First of all, very short comment first on pessimistic forecasts about registration. Anyway, these these machines shouldn't be used as interventional devices. They are not put inside the organism. They are just PC machines, and I believe that artificial intelligence
В нашей стране зарегистрировано
to register in our country. I don't believe that it's going to be a big obstacle, especially if it's going to be our own in-house developments or developments in cooperation with foreign companies. It's not going to be so long and complicated. I don't think so. As a discussion, I have two final slides, and as a ground for discussion, I'd like to ask a question to Michael. A question related to the cost of such systems. I think the key aspect, which is going to be an obstacle for coming this system to the market, will be their cost. As far as I know, the price of Medtronic GI Genius system, which Alessandro Repici told us today about, is so high that when this topic is discussed in Barcelona on the Congress, Professor Armengol said that given such cost, every team of developers have a good chance to promote their own product. So the cost will be the key aspect, I think, in implementing such systems in the clinical practice, and to have a system which you will have to pay $3,000 a month per one working place for a department where there are 10 working places working 12 months a year. Well, even for such rich countries as the US, will be too difficult. What's your opinion, please?
Of course, that's why we have to hope that more systems come to the market soon. The more competition, the lower the prices, and of course the first generation, the early adopters have to pay the price for the others. Second, still in medicine, and this is a phenomenon around the world, is we don't know the true cost of medicine. So we just say, okay, this procedure costs $10,000 or whatever, but we don't know the true cost. So if we find early cancer or polyps and avoid cancer, we avoid surgery, we avoid chemotherapy, we avoid death, we keep patients more healthy, and then they can contribute to society by paying taxes. So I think it's short-sighted to say a single procedure is expensive. We have to do the mathematics to see if it's worth investing the money, but we need the broader picture.
Прекрасно, Сергей Владимирович.
Wonderful. Sergey, please. As far as I understand that we are moving towards the end of our discussion, so let me show you two final slides, which I deliberately left for the end. They are for consideration, for thinking where we are now and when basically the artificial intelligence would be able to replace our own intellect, our own brains. Just take a look. Today we are in the current state somewhere in between, where we have an opportunity to use artificial intelligence in solving specific tasks, expand opportunities of the human brains, process big databases, manage and steer cars, recognize speeches, play Go game, which Mrs. Golkova likes very much, and classify skin cancer, for instance. This slide dates from 2018. In 2018, you see the future of such systems was formulated in the following way. One of the future applications of this system is their use also in surgery and probably in arts. After that, I'd like to show you three paintings, and I'd like to ask you a question, not to Michael, and to the audience. Please tell me which of the three paintings, or maybe all of them, all three or two, were painted not by a human hand. Can somebody guess, or please your guesses, your initiative from the audience? Dear guests, your ideas, please. Which one? The right one. The third one on the right. More versions, please. Three, all three. Wonderful. Ekaterina, please, your version. What do you think? On the right. Okay, those who are familiar with a few unfinished masterpieces, by the way, there are not so many. They understand that the first one is quite famous portrait of George Washington, which was not finished by Gilbert Stuart, and this portrait is a prototype of the $1 bill image, and it is located in New York now. The third painting belongs to a very famous German classic artist, Anton Raphael Mengs. I think Michael recognized him. And there are a few versions why Anton Raphael didn't finish this painting. And one of the versions is that this is a whale on the woman's face. And this is the portrait of Edmond Bellamy, which was created completely by an artificial intelligence, and it was sold at auction at Christie's for an incredible amount of $432,000 just recently in 2018. And this painting was created, it is even signed by an algorithm which was used for its creation and not by a signature of an artist or a group of French young French computer guys who made this masterpiece. Well, I think we are a little bit ahead of time here using the AI, and AI allows to create very serious pieces of art. At this point, this was my conclusion. Sergey, thank you very much. On Amazon, there are already discs available. You can buy music written by artificial intelligence. It's already available. And with pictures, so you surprise us because I remember your question in Yaroslavl Symposium about the picture with football. That was great. Thank you very much. And colleagues, any questions? Anything? Okay, well, comments. Maybe someone wants to have some comments. Please, Michael.
Yeah,
Please conclude.
there is one thing we didn't touch in all these discussions. There's the human interaction between a patient and the doctor. And I think it will still take a lot of time on this until the human interaction can be replaced by computer or by robots. So I think we don't have to worry to be replaced by computer systems, but we should feel the need to improve our knowledge, and also to improve the human aspects in medicine. As an endoscopist, we're sort of glorified plumbers sometimes, so we just clean tubes. But it's much more to it, and that gives me hope that at least as long as I'm working, and I've still got some years to go, I will have to do the work, and the computer will help me, and not that the computer will do his work and I watch him.
Коллеги, сейчас
Dear colleagues, now we have a very important part of our med talk. I invite here to our table Professor Viktor Veselov. Professor Veselov is the man who put the hands and trained the most part of colonoscopists of Russia. It's the most famous teacher of colonoscopy in our country. Please welcome. And Yelena Medvedeva, the head of Pentax office. You know that we have 3 days in the training area. We have 3 days championship on colonoscopy. More than 50 people took part in this championship. We had a very hard selection, and now I'd like to announce the winners. And I must tell you that only one winner will get the prize from the hands of the appendix head office and Professor Veselov. But those who were ranked second and third will be marked by the healthcare department and will be included in the reserve for trips. And of course, there will be a gratitude from the minister. But we really hope that for you it's going to be a stimulus to improve your knowledge, and it will be a proof that all ways are open for you. The doctor of the Infection Clinical Hospital number 2, Rostislav Vorozhaikin, for 2 minutes reached the dome of the blind gut and 27% efficiency, place number 3. Let's welcome. We congratulate you. Thank you very much. The Chief Surgeon, Svetlana Krasnova, will give you all the awards. Thank you very much. You did a great job. You were very good. Next doctor who ranked second, Igor Pakikhin. Eugene Hospital, 1 minute 54 seconds. And 3% pain. Let's welcome the doctor. Thank you very much. Great result. And I'd like to ask Viktor Vladimirovich to do it. I will just announce the results. 1 minute 46 seconds. And what is the time of Professor Kudo? It will be interesting to listen to him. I think less than 2 minutes, of course, for him is an acceptable result. He's very upset when colonoscopy takes more than 2 minutes. He's very upset. He starts to be worried. And zero pain, 0%. Andrei Rozovsky. Is it in general, is it possible to have zero pain? Of course. Colleagues, please, Andrei Mikhailovich, could you take the seat here? Yelena, will you tell us what is prepared for our winner? Thank you very much for your knowledge, for your contribution in the way you work, and for your interest to the profession. And you will have a trip to Japan on the topic you select. Very good reward, Professor. There were a lot of pretenders, a lot of contestants. There were 2 days of selection. We selected the best who had the best time. There were 10 people, and then I took a look how these 10 people made the colonoscopy. Practically all of them were more than 3 minutes. And I didn't work on this simulator, but still I decided before I made the final choice to make colonoscopy on this model. I had 3 minutes. I was not in a hurry. It was just interesting for me. So it is a very good job, very good work on the colonoscopy. Normally, someone say that a person runs very well. Those who run in a sack, it's different. One thing is to make a colonoscopy to a human. Another thing is to do it for a machine. But no, you know, the modern machines, they are coming very close to the level which we should have requirements to in the human colonoscopy. So soon artificial intelligence, I think, will come higher. Coming back to what we discussed today, we're all second signal system derivatives. We have our own intelligence, and our task is to have 4 computers. We have 4,000 endoscopies, 4,000 to train it to do the great job. And then the machines will work better, which will help us. And the main thing is those 2 huge giants, Aquacol and your team, they are focused at training our endoscopists to detect polyps, to train to lead their search, to organize the proper process of colonoscopy. And thanks a lot, all our trips. Yeah, for sure, our colleague was there at these trainings, and it was really not in vain. And I believe this was going to be useful too, that we will have more people who are specialists in colonoscopy in our country. Thanks a lot. Andrei, please, a few words. Many thanks to organizers, of course, and I do my best to attend all endoscopic events organized in our country. It is very interesting to listen to specialists, to share experience, to get more knowledge. Thank you very much again. Dear colleagues, please, everybody who are at the table, and I invite Igor Olegovich and Rostislav Leonidovich to join us. Let's make a joint picture. And please, our conference lasts today and tomorrow. Enjoy it. Thank you very much. Let's get together and make a common picture. Michael, thanks a lot to you.